She will present the first case. And may I request Dr. Srinivasulu, Dr. N.V.N. Reddy and Dr. M.B. Rangareddy to chair this session. This presentation will be for 5 minutes by the student. After that, the chairpersons will ask them the questions. Plus, they will be asking the questions to the students in the hall also. Don't think that you will be escaped. Okay? Along with the student on the dais, you all will be asked the questions. Thank you very much. And I hope you will enjoy the day.
Graduate from Osmania Medical College, and today I am presenting a case of thyroid. My patient Sana Parveen, a 21-year-old female who is a degree student and a resident of Rajendra Nagar, Hyderabad, presented to the hospital with chief complaints of swelling on the left side of the neck for the past 1 year and swelling in front of the neck for the past 6 months. She was apparently asymptomatic 1 year back when she incidentally noticed a peanut-sized swelling on the left side of the neck, which gradually progressed to the present size. It is a painless swelling. 6 months later, she noticed another swelling in front of the neck, which gradually progressed to the present size. There is no history of pain in this swelling. There is no history of difficulty in swallowing, difficulty in breathing, no history of change in voice, no history suggestive of hypo or hyperthyroidism, no history of cough, hemoptysis, no history of bone pains. Past history: there is no history of diabetes mellitus, hypertension, bronchial asthma, heart disease, epilepsy or pulmonary tuberculosis. There is no previous surgical history. There is no history of irradiation to the neck. Personal history: she consumes a mixed diet, takes iodized salt every day. Her appetite is normal, her sleep is adequate, her bowel and bladder functions are normal. She has no addictions, she has no known drug allergies. Menstrual history: she attained menarche at the age of 12 years, has regular 3/30 cycles with normal flow, and her LMP was on 14 January. Family history: there is no history of similar complaints in the family. She has no significant treatment history. On general examination, patient is conscious, coherent, cooperative, moderately built and moderately nourished, comfortably sitting on a stool. She has no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy and pedal edema. There are no eye signs. She has no tremors. Her vitals: pulse is 76 beats per minute, regular rhythm and normal volume. Her blood pressure is 110 by 70 mm of Hg measured in the left arm in supine position. Her respiratory rate is 13 per minute and her temperature is 98.6 degrees Fahrenheit. Local examination. On inspection, sir, I'll first describe the swelling in front of the neck. There is a butterfly-shaped swelling of about 3 by 5 centimeters in size, located in the lower part of the anterior aspect of the neck in the region of the thyroid, extending superiorly to the thyroid cartilage, inferiorly till about 2 centimeters above the suprasternal notch, and laterally till the anterior border of sternocleidomastoid on each side. The superior and inferior borders are clearly visible, while the lateral borders are indistinct. The surface of the swelling appears nodular. The skin over the swelling is normal. There are no engorged veins, scars, sinuses. The swelling becomes less prominent on extension of the neck, and the swelling moves up and down with deglutition. This is a video of the swelling moving up and down with deglutition. Coming to the swelling on the lateral aspect of the neck, there is a vague fullness noted in the left supraclavicular fossa, measuring about 4 by 4 centimeters in size, with ill-defined margins. The surface of the fullness appears smooth. The skin over the fullness is normal. There are no scars, sinuses or ulceration. On palpation, I'll first establish swelling on the anterior aspect of the neck, sir. Inspectory findings regarding the size, shape and extent are confirmed. The swelling moves up and down with deglutition. There is no tenderness. The swelling is uniformly firm in consistency. The surface is nodular with 2 nodules palpable involving both the lobes and isthmus, left measuring 4 by 3 centimeters and the right measuring 2 by 3 centimeters. The swelling is mobile horizontally and vertically independently of the trachea, and plane of the swelling is deep to the deep cervical fascia. There is no palpable thrill. Carotid pulsations are felt at their usual site at the upper border of the thyroid cartilage. Trachea is centrally placed. The swelling on the lateral aspect of the neck is a solitary globular, well-defined, discrete a non-tender swelling of about 4 by 5 centimeters in size in the left supraclavicular fossa in the region of the level 5B cervical lymph nodes. The swelling is freely mobile in both the directions, has a smooth surface and is uniformly firm in consistency. So the swelling plane is deep to the deep cervical fascia. There are no other cervical lymph nodes palpable. Percussion over manubrium sternum yields a resonant note. On auscultation, there is no bruit heard. Systemic examination, heart sounds S1 and S2 are heard. There are no additional sounds, no murmurs. Bilateral air entry is present in all lung fields with normal vesicular breath sounds, no adventitious sounds. There is no focal neurological deficit. Her abdomen is soft, no organomegaly, no evidence of free fluid. There is, on examination of the musculoskeletal system, there is no bony tenderness, there are no bony swellings.
Then we'll start discussing. Dr. Keerthana, very good presentation, very fast, very meticulous, very clear. And this everything is good. Keep it up in the examination, particularly the first year and second year students should go like this. On inspection, you said surface is not blurred, a solitary swelling visible on the left side. The sternocleidomastoid tracheal deviation is not there. Sternocleidomastoid is prominent on which side? On the right side. The swelling is on the left side. The lateral margin is diffuse, going under the sternocleidomastoid.
Yes, so the thyroid swelling is the nodule on the left lobe is bigger in size, sir. So
But on inspection, only one swelling, solitary swelling, or two solitary swelling, two swellings you are seeing on inspection.
there is a nodular surface on inspection also, sir.
No, madam. On palpation, you said there are two swellings are there.
One the thyroid and one the lymph node, sir. On the thyroid also there are two nodules.
Please ask.
In your presentation, you said swelling moving upwards and downwards with the. In your presentation, you said the swelling is moving upwards and downwards with the deglutition. Which textbook has written like this? Upwards and downwards. Why do you say upwards? What is the cause for moving upwards and what is the cause for coming downwards? Can you say?
It is written into the normal position.
Why thyroid swelling is moving upwards with the deglutition and why it is coming down?
The thyroid is enclosed in the pretracheal fascia,
So-
which is condensed posterolaterally to form the ligament of Berry. Ligament of Berry is attached to the thyroid and cricoid cartilage.
Okay, very good. Why it is coming down? Why it is not staying there? What is the cause for the thyroid to come back to the normal position? This is a question which is asked in the PG examination.
There is a space between the true capsule and
What
false
is the
capsule.
cause for the swelling to come back to normal position? Why not staying there up?
Thyroid
We should
has-
say this swelling moves upwards with the deglutition. Stop here. Don't say upwards and downwards. Why it comes downwards?
I meant to say it returns to its usual.
What is the reason why it is coming down? The thyroid comes back down because the elastic recoiling effect of the tracheal rings. Okay.
So my provisional diagnosis is a papillary carcinoma thyroid with metastatic level 5B cervical lymph nodes.
Differential diagnosis. Then pathological diagnosis also. Papillary carcinoma. Why can't it be follicular? Why can't it be medullary? Why only papillary?
It's likely to be papillary, sir, because papillary.
Better safest carcinoma thyroid, probably papillary, rather than directly doing papillary carcinoma thyroid. So there is diffuse enlargement of thyroid according to you. It's like a multinodular bite.
Yes, sir.
If there are no lymph node metastasis, your diagnosis would be a multinodular bite.
Yes, sir.
What is the reason for the diffuse enlargement of thyroid?
Papillary carcinoma can be multifocal and multicentric, sir, because of intrathyroidal lymphatic spread. So it can rarely present as a multinodular goiter also.
Multinodular goiter, multicentric papillary carcinoma, or is a papillary carcinoma arising in the background of
In the back
multiple
of the
nodules.
What do you mean by multicentric and multifocal?
Multifocal is multiple areas of malignancy in the same lobe, sir. Multicentric is in both the lobes and distance.
Queries actually. I'm surprised that you have labeled this swelling as a butterfly shaped swelling and your measurements on both right and left sides are different, if I'm not mistaken.
Yes, sir. The left
Is
side
it truly a butterfly, a bilaterally symmetrical swelling which you...
It is not symmetrical, sir. The left side
Your
is more prominent.
inspection and palpation you have been emphasizing it's a butterfly shaped swelling, which is of course it is not based on the clinical. Second thing, I'm surprised that in your family history, you said there's no relevant family history and there's no history in the neighborhood actually. Why did you bring in this history of similar swellings in the neighborhood in the family history?
Actually, I didn't know where else to put it, sir.
So you would like to include that, do you think, suppose if the neighborhood people are having a similar swelling, is it something to do with the familial inheritance of the disease?
No, sir. I was trying to rule out endemic goiters.
What is the importance of this familial history in case of a thyroid? Because you have already given a diagnosis of carcinoma thyroid. How do you probably relate it to the familial inheritance as far as thyroid carcinoma is concerned?
The strongest familial inheritance is associated with medullary carcinoma thyroid, sir. While papillary carcinoma can also have a familial inheritance. Strongly associated with medullary carcinoma. Sir?
You said shape.
Yes, sir.
Then you have gone to extent of the swelling. Did you mention anything regarding size?
Yes, sir. 3 by 5 size. 3 by 5 centimeters in size.
Actually, the presentation is alright, but during your presentation you said butterfly shaped swelling with a uniform measurement of 3 to 5 step. That is a butterfly shaped swelling with a larger wing on the left side.
Yes.
That would have been better for you.
You said butterfly shape with one solitary nodule. What is the definition of the solitary nodule? Can we call this as a solitary nodule?
I would call
Taking this lateral swelling for some time away from this.
I would call it as a dominant nodule of a multinodular goiter.
How do you
Because
say
the
that
left-
clinically?
So clinically on Kryle's method of palpation, there are nodules on the right side also, sir. The left side is definitely bigger, but there are nodules on the left side also.
What is the definition of the solitary nodule? Can you define solitary nodule? Anybody in the final year or any postgraduates, please? I wish 2-3 more postgraduates of the final year come over here, participate in the debate. I think that sounds well, because you're not the only candidate appearing for the examination. Come please.
We have the 3 to 4 years, please.
Not polite exam going students. Please take the mic, answer the question. Definition of solitary nodule.
Palpable nodule in otherwise normal glands.
Yes. It is a visible or palpable solitary nodule in otherwise impalpable thyroid. Normally thyroid is not visible, not palpable. Once you see that or palpate it, probably this is a dominant nodule of a multinodular goiter. Yes. Sir, the examiners will ask only clinical discussion, first clinical presentation 10 minutes, then diagnosis, differential diagnosis, then investigations and management. We'll go systematically rather than bombarding the questions.
I think you said carotid pulsations. This is meant for everybody. Where do you look for carotid pulsations in a thyroid swelling? You said upper.
Use the mic.
At the level of the upper border of thyroid cartilage at the anterior border of sternocleidomastoid against the transverse process of the 6 cervical vertebrae.
Is it correct? Any difference?
Use the mic. Give another.
Anterior tubercle of the tip of the transverse process is 6
See, what is the sign? Carotid pulsation, thyroid, what is the sign?
Yes.
Very sign. Yes. See, here, you are to palpate the carotids lateral to the thyroid swelling, not above the thyroid swelling.
In front of the patient you stand. Where do you stand in relation to the patient while palpating the carotids? By the side.
Behind or by
Which
the
side? Right side or left side?
You can palpate from both sides.
Is he right or wrong? You stand in front and feel carotid pulsations. Anybody differs? You stand behind the patient
Behind the patient, turn the head to the same
and
side.
feel both the carotids at the same time.
You will not.
Should not.
And don't palpate in standing posture also. That is also important. Patients can sometimes collapse. So make the patient sit, then palpate. You have to palpate behind the most prominent part of the thyroid swelling. Here, the thyroid is malignant. It encloses the carotid vessels, so the pulsations will not be felt. If it is benign, it pushes, the pulsations will be felt posterior to the swelling. So that is a theory. But almost never this sign is possible. But even if anaplastic also are able to feel the carotid pulsations pushed away. But clinical sign, it is not above the thyroid gland. It is behind. It's a one thing. No. It is a level 5. Many times I think examiners may not just accept if you say level 5. You have to define anatomical area. How do you differentiate level 4 from level 5?
So level 5 is posterior to the sternocleidomastoid. Sir.
Level 4? 5 is posterior. 4? Behind. What is the difference between supraclavicular node and level 4 node or level 5 node? Same or different? Where is the Virchow's node or Firko's node? The correct pronunciation is Firko. So where do you find Keerthana?
It's between two heads of sternum.
Between the two heads of the sternocleidomastoid. So completely behind is level 5. Yes. What is the lymphatic drainage of thyroid?
It drains into the pre-laryngeal, pre-cricoid, pre-thyroid, parathyroid, pretracheal and paratracheal group of lymph nodes. These are the central group of lymph nodes, sir, and from there to the lateral group of lymph nodes. Sir, level 6, sir. 7 is tubular mediastinal lymph nodes.
Still 7 is considered as a lymph nodes.
7 is superior mediastinal lymph nodes. They are extension of level 6. And they are also considered regional nodes for the thyroid.
Even today they are considered.
Yeah, same.
I have a very strong objection in you giving a pathological diagnosis. I would not have probably accepted that diagnosis. Can you just modify your diagnosis? Because I'm not happy with the way you have given a pathological diagnosis saying that it's a papillary carcinoma with secondary.
I would say that it is a malignant multinodular goiter with
Please. See, don't give pathological diagnosis, but you can give the diagnosis of carcinoma of the thyroid. Don't say multinodular goiter again. Don't bring trouble to yours. There are lymph node metastases. It is carcinoma of thyroid. You don't say clinically. Clinically, it is a carcinoma of thyroid with lymph node metastasis. Level 5 lymph nodes, yes.
so the patient presented with lymph node first and then swelling in the thyroid later. And papillary carcinoma is most commonly associated with lateral cervical lymph node enlargement and there are other malignancies.
Is it necessary always like that? The papillary carcinoma starts first in the lymph nodes
No,
and
sir.
then...
In this patient, it
Because
starts.
you said it is in favor for this reason.
Yes.
It doesn't hold good. And lymph nodes are not palpable in other malignancies?
They are, sir. They are commonly palpable in
Commonly. Less commonly in which conditions? Which carcinomas?
even follicular carcinoma can present with lymph node
Can
metastasis.
present.
Medullary carcinoma.
Medullary carcinomas. So that doesn't go in favor of that.
This is total carcinoma thyroid, probably papillary. Other possibilities, medullary can be there, follicular.
Follicular also.
What next? What are you going to do? No.
Apart from routine investigations, I would like to do some investigations to confirm my diagnosis, sir.
What are they?
I'll do an ultrasound of the neck first and an FNAC of both the thyroid swelling and the lymph node swelling.
Lymph node swelling means which area you ask?
There is a palpable level 5 lymph nodes.
No, ultrasonologist, what do you ask? The thyroid region and
Ultrasound
neck
of the
you will
neck.
say.
Ultrasound of the neck.
Don't say for lymph nodes.
FNAC of the lymph node.
Okay.
FNAC of the thyroid swelling and the lymph
FNAC, do you use the help of USG in this case?
Yes, sir. Because I would like to take a guided FNAC because there may be areas of cystic degeneration and FNAC may not yield good result in the first setting. I would go for.
Are you feeling cystic nature in this case? No. Therefore, straight away you would do anything. How do you do FNAC?
I would first prepare this swelling with spirit swab and then put a 26 gauge needle into the swelling, sir.
Which needle?
26 gauge needle.
26, okay.
And then I'll move the needle perpendicular to the swelling 3 or 4 times and then aspirate. If it does not come with just moving the swelling for
It's
needle.
not the way to do no aspiration.
Posture. Lying posture.
Sitting posture.
Sitting posture. Why you prefer a sitting posture?
Lying down posture.
Yes, sir.
Always do in a lying down posture. Don't do in a sitting posture. You do ultrasound neck at the same time you do
If they-
ultrasound guided.
Ultrasound.
FNAC and FNAC technique is not correct. What you said is introduce the needle, then aspirate, maintain the negative pressure,
Negative pressure.
and then pass in different directions.
You do 3 to 4 passes. As you rightly put it, perpendicular to the gland. Then what you will do next? And keep the pressure, negative pressure, constant when you are withdrawing the needle. Right. Then
Then release the pressure.
What you will do
remove the
next?
needle.
I'll put it on a slide and fix it with
and you will
alcohol.
see at the hub of the syringe, there is some fluid. Then you take away, keeping the negative pressure intact and spray on the
Or a
slides.
prima slide.
3 types. One is dry, another is 70% alcohol, another is 90% alcohol. Then you go for a stain. This is the procedure. Supposing when the needle you have put and drawing, there is a blood has come, what you will do?
I'll apply pressure and reintroduce the needle from some other side.
In this,
Dr. Keerthana, what is C score?
Sir,
What is C score? Cytology score.
there is a Bethesda classification, there is Thai classification, sir. Thai 1 is an inadequate specimen. Thai 2 is cystic. Thai 3 is a neoplasm. Thai 4 is suspicious of malignancy and Thai 5 is...
Azra, you tell what is C score?
Thai 0 insufficient specimen. Thai 1 cystic lesion. Thai 2 benign lesion. Thai 3 follicular lesion. Thai 4 probably malignant. Thai 5 malignant. 6 proved.
Fine needle non-aspiration cytology or still you prefer to do fine needle aspiration cytology when you are suspecting a thyroid malignancy?
So if the ultrasound shows that it is a very vascular swelling, I will not go for an aspiration.
What is this fine needle non-aspiration cytology?
Without aspiration, the material directly comes into the hub of the needle. So,
What are the types of cytology? What are the types of cytology? Say one is FNAC, the other is FNNAC. What are the other types of cytology, you know?
brush cytology.
Example, from where you take brush cytology?
From a cervical
Bronchus.
bronchus.
Usually. Next, what else? FNAC, FNNAC, brush cytology. Okay, what are the cytologies, you know?
Exfoliative.
Very good example.
From a pap smears.
Pap smear is scrape cytology. Expose cytology is any gastric ulcers, urine examination. What else? So far, how many you told? FNAC, FNNAC, scrape cytology, exploratory cytology. What else? Imprint cytology. What is that? suppose there is a lesion, take a slide, place against that, take out and see under microscope. That is called as imprint cytology.
Yeah, we'll go to management. Actually, this is a good lesson for you. Don't expect questions in the examination in a predictable way. Sometimes examiners will ask questions totally out of the way. You should not get perplexed, answer them and do well. Don't get hesitated. So you are not expecting this question at all. But this happens in the exam. Because what happens, the way you presented, you are going to answer everything about thyroid. So we want to ask you.
Define cyst.
Yeah.
Sir,
Define cyst.
an epithelium lined cavity filled with fluid.
What is the classification of cyst?
Yeah, we are getting that. We will come to this. Thyroid. Yeah. So what are you going to do now? So you have done a FNAC, you have done a ultrasound, your findings are confirmed, and it's papillary carcinoma of thyroid. What do you see in papillary carcinoma of thyroid on FNAC?
I see orphan amnioid nuclei and some of my bodies. And papillary projections.
Yeah, sometimes you get papillary projections also. Okay. Then what are you going to do? What next?
I would plan for a total thyroidectomy with selective posterolateral neck dissection, sir.
What is posterolateral neck dissection?
I'll remove level 2 to level 5 cervical lymph nodes.
What about level 6?
I'll do only a therapeutic central neck node dissection, sir.
Pardon?
If it comes as
There is
papillary.
another important thing, everybody remember. The moment lateral lymph nodes are there, the central lymph nodes have to be removed. They are the first echelon. Whether they are enlarged or not, you have to remove the first echelon and then only go to the lateral neck. So total thyroidectomy, central neck dissection and posterolateral, the word used, okay. 2, 3, 4, 5 are going to remove. Why are you not removing level 1?
Level 1 is very rarely involved in thyroid malignancy, sir. So I will go for a selective
Okay.
dissection.
What about the opposite side?
I will not
Opposite
go for
side
a
is the
prophylactic dissection, sir. Only if they are involved, if they are found on ultrasound as subcentric nodes, I'll try to take an FNAC, and if they are involved, then only I'll go for a therapeutic dissection.
Don't use the term prophylactic. That is not prophylactic, that is
If they are
elective.
involved, I'll go for a therapeutic
No.
dissection.
Don't use the term prophylactic neck dissection. It is an elective neck dissection. So prophylactic is used interchangeably, but better to use the term elective. Yes. After that, what will you do?
No, sir. I'll not use.
Okay, great. What next?
After the surgery, I'll go for a radioactive iodine scan 6 weeks after surgery, sir.
How do you prepare the patient for?
If necessary, I'll give L-toxin, sir. But if it is available, I'll give T3 for about 4 weeks and then stop it for 2 weeks and put the patient on a low iodine diet for 2 weeks and go for a scan 6 weeks later, sir.
Where do you want to start on T3? Patient is not tolerating, that's what we say. Not tolerating
If the
hyperthyroidism.
patient is not tolerating.
So what is the best way of dealing with that? What is the best way of dealing? Not starting on T3. You can replace thyroidism and then do what?
Yes. And
You recombinant
recombinant
TSH and do it. Yes. What are the? What do you? Yeah, yes.
Thyroidectomy.
Yes. There is nothing. Then what do you do? So look,
Process according to ages or MS or
what is
MESIS
the
criteria,
prognosis?
sir. There are criteria, sir. Ages, MS and MESIS criteria. I'll grade the patient according to the histological grade, age, extent of extrathyroidal spread and the size of the lesion, sir.
Clinically, high risk or low risk or intermediate risk?
Low risk, sir.
Low risk. Extrathyroidal spread is there.
Extrathyroidal spread.
So, what is the risk? That's why you are giving radioactive iodine. If it is really low risk, you don't go for
You don't
radioactive
go.
iodine. Yes. How do you follow up this patient?
I'll measure thyroglobulin annually, sir. And along with thyroglobulin, I'll also measure for anti-thyroglobulin antibody at the same setting.
what else you will do after radioactive iodine scan? You will replace with
I'll give lifelong
Thyroxine?
thyroxine supplementation.
how much thyroxine?
I'll give a suppressive dose of thyroxine, sir, about 150 to 200 micrograms of thyroxine.
So again, this is not actually suppressive, that concept has gone. Should maintain the TSH level in the normal range, lower level of the normal range. Previously undetectable. Now the current recommendation is maintain it in the lower range of the normal TSH values. Okay? So you need not give hyperthyroid doses. Euthyroid with them. That is enough.
What about the role of USG in follow-up? What are the various modalities you adopt in follow-up for this case? One is TG levels, you said. Second is, we do USG I-131 evaluation. If so, how frequently do it?
Ultrasound, I'll do it in the immediate post-op period, sir, to look for residual thyroid in the thyroid bed. I'll also do serial ultrasounds every 2 to 3 years to look for any other lymph nodal enlargements. Only if the thyroglobulin levels are elevated.
Yes, every 2 to 3?
Only if the thyroglobulin levels are elevated, I'll go for imaging investigations.
Otherwise you don't want
Otherwise,
to.
I'll not want. I'll not.
USG, if it is necessary, you will do after 6 months once, 12 months after surgery. Annually, you repeat 3 to 5 years. Supposing I-131 USG are negative, they are not inconclusive. Still the TG levels are raised. What modality you would like to know whether there are secondaries or not? If so, where? Any other investigation?
Papillary, if it comes as papillary carcinoma, it is a very
Not it
differentiated
comes,
carcinoma.
your case is confirmed
Papillary
papillary carcinoma of the thyroid with level 5 secondaries.
If the thyroglobulin remains persistently high, I'll first give a recombinant TSH and look for a radioactive iodine scan again, sir. If that also does not show any lesions, then and still thyroglobulin is elevated, I'll go for a PET CT, sir.
Give me detail what type of PET scan you do, what is it?
18-fluorodeoxyglucose PET, sir.
Yeah, right.
These went out actually. You have just done an ultrasound. I just go back a little when you said that you want to do, particularly when you have a lymph node and a suspected malignancy. Is there a role for further imaging? Would you like to just stop at ultrasound, or would you like to plan for some other imaging modality, at least to stage the disease?
I'll go for a CT neck and chest.
Absolutely no role. This is a classically operable disease. X-ray chest is enough as far as anesthesia workup is concerned. You don't do any CT here. When you do a CT, there is what is CECT, contrast enhanced with iodine contrast, something called thyroid stunning error. So unless absolutely indicated, don't go for a CECT. That is number one. If at all it is indicated, but to go for MRI rather than CT. And a patient like this, where the thyroid is fairly mobile, nodes are fairly mobile, you have no issues at all. There is no need to do any other imaging apart from ultrasound of the neck. Just X-ray should be enough. That too as part of anesthesia workup. The radioactive iodine scan post-operatively is going to be the best staging investigation.
Yeah, the organizers have told us instead of 40 minutes, make it 35 minutes, so that 5 into 3 long cases, 15 minutes can be recovered. So 4 more minutes. So you can ask some more questions related to thyroid. Yeah,
What are the
yes,
post-operative complications of photothyroidectomy?
post-op.
What are the post-operative complications of photothyroidectomy?
There are on-table complications, immediate post-operative complications, and delayed complications, sir. On-table, there can be hemorrhage, injury to the recurrent laryngeal nerves, injury to the parathyroids or the blood supply. Immediate post-operative complications include a reactionary hemorrhage, tracheomalacia, and laryngeal edema.
Tracheomalacia?
In a long-standing multinodular diffuse goiter causing pressure effects on the trachea, it can precipitate a tracheomalacia, sir.
The lady, doc, you take the mic. In this case, what is the advantage of total and near total in this? Mic nearer to you. Yeah.
Please repeat, please repeat.
Bring it near to your mouth.
If we do total thyroid.
Don't say if you do. Don't say if you do.
Always use the word I.
And do total thyroidectomy to
Okay, tell me the salient steps of total thyroidectomy.
sir,
Operative surgery. How you proceed? Patient is posted. I am your assistant professor. I kept him on the table. This lady on the table. How do you proceed?
I give the incision 2 centimeters up.
Don't start straight away incision after putting the position of the patient, draping of the patient to talk. What is the position you put it?
Position and make the head rose position, sir. Hyperextension at the neck.
Your example? You're good. No, don't get disappointed.
What is the difference between total and near total? I think that concept should be very clear. What do you do, total or near total?
Total thyroid.
That's all. You have to do total thyroidectomy. While doing total thyroidectomy, you have to save both the recurrent laryngeal nerves and parathyroids. While trying to save the parathyroids and recurrent nerve, without your knowledge, inadvertently, you leave behind some thyroid tissue. So what you thought is total thyroidectomy, after radioiodine scan becomes a near total thyroidectomy. So you don't do near total thyroidectomy intentionally. Your intent is to do a total thyroidectomy. You may leave behind some thyroid tissue, and this thyroid tissue is normal thyroid tissue. And that's what we are going to apply in the postoperative period.
So one doubt.
How do you recognize the recurrent laryngeal nerve during surgery? Where do you look at it? Look at it.
In the tracheoesophageal groove, the lower pole of the thyroid, posterior to the, mostly it will be posterior to the inferior thyroid artery.
It is the triangle. Between them, medially it is bordered by trachea, laterally by the common carotid, superiorly by the inferior pole. Yes, they will trace it. What is the post-operative? You are on duty, you are called. The patient is breathless 6 hours after surgery. What is your plan after seeing the patient?
Hematoma.
Hematoma. Where?
In the neck region, swelling.
So what you will do?
Immediately I put the pressure and
Pressure where?
we remove the sutures and look for the
Sutures. Which sutures you remove? You're right. Which sutures?
along the line of the.
What are the sutures that we put during surgery after thyroidectomy? First you will close the
Strap muscles. Then the platysma.
Next, please.
We have to open up to.
Not we. I am not there with you.
I will open up to strap muscles.
Up to strap muscles means
Sutures.
you have to open the skin sutures or clips, whichever you have put, as well as the deep fascia. Is it not? It is a collection posterior to the deep fascia. Unless you evacuate it, there will be continued compression will be there.
Why breathlessness occurs or breathing difficulty occurs when there is hemorrhage or hematoma? Why? What is the reason?
Expanding hematoma compressing the
Compresses what? Compresses what? Trachea. It will compress the trachea and cause breathlessness.
It will precipitate laryngeal edema.
Yes. Causes laryngeal edema. Already you have put a tube and removed the tube. And then there is compression of the venous and lymphatic drainage from the larynx. Laryngeal edema, that is the cause of breathlessness, not direct compression of the trachea. The moment you
Suggestion to you. Whenever you see a case, present yourself to your colleague and your colleague only ask only one question, why, how? Then the answers will come. Simple. Okay? Practice this.
What is the nerve of amygdala?
Thank you very much, sir. I think she'll be there, you will be there too. When you all come to the days, you can ask her that question.
This is Galley Curtsy.
Okay, I think, sir, the line should stop here. Thank you very much. Keep
to present the mementos to the chairperson.